2, 1. Sir, we are live now.
Okay, good evening, everybody. Welcome again to this evening's webinar, brought to you from the Orthopedic Research and Education Foundation, being relayed through Ortho TV. Today, we have the pleasure of having Dr. Ritabh Mittal from Spinal Injuries Hospital, New Delhi. Ritabh is a very, very keen teacher and has been involved with the AO for many years. And it will be a pleasure to listen to him today. He's going to talk about biomechanics of implants, basically for implants used in fracture fixation. So over to you, Ritabh.
Thank you, sir. Thank you for the kind words. And it's an honor to be part of the association and welcome participants. It may sound a little intimidating, but we will go through some of the meanings of the words that are commonly used in mechanics. And in terms of implant, we know that there is stainless steel and titanium. So we'll briefly talk about what are the salient differences between them. We'll discuss a few clinical cases to apply the mechanical knowledge that we have learned during the course of this presentation in the clinical cases. And I would be interested in learning from your questions. So coming to the first word, we talk of strength of a material, strength of the implant. By strength, we mean the ability of a material to withstand loading without failure. So we've seen so many IPL games, cricket around the world. We rarely see the bat breaking. And that is what happens in orthopedics too. Sometimes things happen. So the ability of a material to withstand loading repetitively without failure. What is failure in terms of orthopedics? Failure means a change in the shape of the device. It could be a plate, it could be a nail. So in this case, we see a stem, a femur stem on the top of the image. During the surgery, the patient had an iatrogenic fracture. The staples are still visible. The fracture was fixed, but the plate has started deforming within 10 days of fixation. So this is failure. So this tells us that the strength of the implant was not sufficient. Failure, on the other hand, could mean break in the implant, which we more commonly see. The second term we talk of is stiffness of the implant. Stiffness means the ability of an implant or material to resist deformation. As you can see this high-speed image of a tennis ball hitting the racket, there is a deformation in the racket cutting as well as a change in the shape of the ball. So all devices, when they interact with each other, do deform a little. Sometimes it is visible, sometimes it is not so visible. So this is an implant fixed to the tibial bone in a minimally invasive manner in a bridge mode. And on your right is the implant fixed to the femur bone, similarly in a bridge mode. The working length of both the implants is the same, but the tibial plate has deformed. So the stiffness of the tibial plate was much less compared to the femur plate. So when we talk of the two words we have so far learned, loading and deformation, this is a classical example in real life of a car tire, which is on loading, you see the tire, it has deformed. So this is what usually happens in real life also on a scale that is much less visible to the naked eye, but is appreciable by the biological cells and tissues, and their response over time is what we interpret on images. Now coming to loading. Loading is also a force. the synonym for force is also stress. Now, these forces or stresses could either be static or dynamic or repetitive. So when we talk of biomechanics, to understand things, we talk first in terms of static stresses, that is axial stresses, bending, and torsion or twisting stresses. But what happens in real life is that all these forces are acting in combination together. The contribution of the various forces may vary. We will come to that in the subsequent clinical examples. Sometimes we see pure spiral fractures. Sometimes we see spiral fracture with 3-4 fragments. It means that the initial contribution of the spiral force was probably more, but then axial compression caused the fragmentation of the bone. So now we will take each force. So this is example of a loading or axial force. So axial forces tend to lengthen or shorten the bone. So this is a multifragmentary fracture. If not splinted by a material or a plate, you can now see that the limb is shortening or lengthening on functional loading. Sometimes the limbs shorten, as you can see the bones overriding. Sometimes they lengthen. So axial forces essentially mean they tend to shorten or lengthen the bone. Next is bending. Bending forces tend to angulate the fracture. Bending forces tend to angulate the fracture as seen in this example. So you can see an 5-year-old boy whose fracture femur plates, even the adult plate failed, possibly due to reasons that we'll understand as we progress in our presentation. And bending forces tend to angulate the fracture. Angulation, as you can see in the examples here. The third load or stress that we talk of is torsion. Torsion forces, as the word implicates, tends to twist the fracture. So as you can see in this presentation video, fracture fragments are twisting on loading. These tend to cause rotatory displacements. So rotation is something that is better appreciated clinically, radiologically. But in this presentation, if you see, proximally the plate and the screws are visible in profile, but distally the distal femur and proximal tibia seem to have rotated out of place. So rotation is a displacement better appreciated clinically. So we are now aware of the 3 loading forces that we have seen. Now we talk of deformation. Deformation means change in shape. Change in shape, it could be a change in length, like the tennis ball, it changed in shape from round to a little oval. The car tire flattened out a little bit. Change in shape is called strain in mechanical terms. So this is an elastic band the lady is exercising, and it's changing in length and coming back to its original length. So we now introduce another term of elasticity, ability to deform and then regain the original shape. So let's take a break here. So we have covered the strength of an implant, the stiffness of an implant. The same definitions apply to strength of bone, stiffness of bone, and deformation of bone. So this is a video made in 1968 showing what happens to bone when it is axially little bent and torsion applied. So all the 3 forces applied to a dog femur. This is a 40-second video, and please just observe it. There. This is a slow motion showing how bone has fractured. And now, once you reverse the video, you will see how we can reduce it. This is naked bone. The soft tissues, in fact, reduce the displacement of the fracture. If the soft tissues weren't there, these fractures would have flown out. So this is the kind of injury, and this is what happens in a microsecond in real life. So, coming to stress-strain relationship, you all must have seen this diagram, this graph. So, A is the elastic zone. When the load is removed, the material regains its original shape. So, when we run, we walk, we jump, our bones ever so lightly deform in shape, but we are ready for the next step or the next jump because the bone is elastic within a certain limit. Similarly, implants are elastic within a certain limit. C is known as the yield point. Beyond C, when the load is removed, the structure or material does not come back to its original length. A certain amount of deformation is inevitable. So this is known as the limit beyond which plant is now working in its plastic region. As an example here. So the femur was plated and within 2 weeks, the deformation began. So the implant is now not going to restore or regain its original length. It will stay deformed. So on functional loading of this limb, muscle contraction, the deformation will markedly increase with a slight increase in stress, as can be seen from this graph. A slight increase in stress causes a marked increase in deformation. So this is doomed to fail, this fixation, because the implant is now in its plastic region. So we'll take the stress-strain relationship of 4 different materials seen here. So if we see the blue line shows that on high stresses, there is very little deformation, But the moment there is deformation, there is no further line. It means that the material just breaks. So this material, blue line material, is very strong, very stiff, but suddenly breaks. So an example here is glass. The red line is also strong, also stiff, and deforms a little, but then breaks. So its ductility or resistance to failure or the plastic deformation zone is very less. This is titanium. The green line is strong, has good strength, has good stiffness, but has a wide plastic zone. So it is a ductile material. It stretches out, gives some time before it breaks catastrophically. This is stainless steel. And the purple deforms very much given very little stress. It just deforms. So this is polyethylene or something like rubber. It has no ductility, it has too much of ductility, but it has no inherent strength in itself. So we can't make implants out of polyethylene, although the drive is on to find out implants which do not need surgery to get removed for small bones, but they don't have any strength or stiffness. Now I will like to introduce you to a word, moment. Like a moment in time, this is in physics a moment. Moment is a type of force. The only difference is the force is like this gentleman tightening the nut on the spoke. A force that changes movement. Movements are either in bending, these rotatory in bending stresses, or in torsional stresses, loading of the bone. So to take a breather, we have understood what the strength of a material is, that how much load it will take before it fails. Stiffness is how much will it resist deformation. Loading forces are axial, bending, and torsional. We have understood the relation of stress and strain, and we have been introduced to the word moment, which is a type of force that changes its direction as it is applied. So, how does a structure resist deformation? How does an implant resist deformation? How does someone or something resist deformation? Sumo wrestler resists deformation simply by the body weight, his mass, what we call inertia. The heavier he is, the better he will be able to resist any push. So let me take you through the example of someone pushing a car. If this were a truck, two people would not have been able to do it. This is a car, so the two people may be able to push it. So the concept of resistance or inertia is simple when thought of pushing in a straight line. You have to push some object, it's understandable intuitively. You have to push, and the heavier it is, the stronger the more force you will require to push it. Now think about this man, Philippe Petit, walking the line, a very famous picture made on this gentleman who walked across the Twin Towers. So he is trying to resist movement, not primarily in the forward direction, in the rotatory direction, so that he doesn't fall off. So how does an object resist deformation in rotation? Yes, the mass does matter, but if you see this gentleman, apart from the mass, he has moved his arms away from the body. What does this do? And in the previous example, you saw Philippe Petit, he was carrying a rod, a long rod in his hand. So what does moving the hands away from the body do? It basically changes the distribution of the mass. So this is a concept to understand that it is not only mass distributed from the center that prevents deformation in the rotation. So what has nature done with this concept? To make you understand this, we'll go through an example here. This is a 23-year-old lady's bone, fixed femur fracture fixed with a nail. And this is a 83-year-old lady whose fracture is about to be fixed. So what you can see in the young lady is a thick cortex. What you can see in the elderly lady is a thinner cortex. If you try to push in a nail in a young lady, the maximum we can go up to is a 9 or 10 mm nail. But in an elderly, 11, 12 nail also goes in. So why has this happened? How has nature understood this concept and applied it to the human body? With aging, as the amount of bone is reducing, nature distributes it further from the central axis, away from the neutral zone of the bone, away from the bone, so that given the same amount of mass, the wider it is, the structural strength of the bone can be better. Another example of nature using this concept of distribution of mass away from the center is in a callus or healing bone. As you can see in this X-ray, you can see callus. An earlier X-ray of this healing bone shows a cauliflower-like callus. So the diameter of the callus is much more than the diameter of the bone. The initial callus is made up of soft callus. So the material is soft, but as it is distributed further from the center, the complex of callus and the bone together can resist the deformation much better. And as the callus starts getting harder and the bone starts maturing, you will see that the callus starts narrowing. And in final stages of remodeling, the bone restores its original shape. So nature too uses this concept of distribution of mass away from the center to reduce deformation of healing bone. Coming to the second learning outcome of stainless steel versus titanium. If we can see the strength is the same, almost the same. Megapascals is the strength unit is megapascals, and the resistance to deformation is significantly higher, almost 1,000 times higher. If you see the stiffness of stainless steel, it is double that of titanium. So it needs much more loading to deform compared to titanium. If we compare this to the stiffness of original cortical bone has a stiffness of only 20 GPa. And cancellous bone has an even lesser stiffness. The problem is these are all static values. In real life, most of the stresses are cyclical, like the rocks shaped along the seashore by the waves over years, thousands and billions of years. Similarly, once a fracture is fixed with an implant, the implant and bone complex are subjected to repetitive cyclical axial, bending, and torsional stresses from the very next moment that the patient comes out of anesthesia. Muscle forces act even if the patient is bedridden, and they act in different directions, and the bone and the fixation is loaded from the moment patient is out of anesthesia. So we'll take an example to compare stainless steel and titanium. So this is a proximal femur fracture fixed with a DCS. And in 3 months, you can see something. The implant is well fixed, but the shape of the implant has started changing. This is a fracture femur fixed with a titanium plate. A titanium plate gives no time, it just breaks. So this happened to the gentleman's left femur 6 months down the line. The patient had a bilateral shaft femur fracture, had bilateral plating. The left side broke at 6 months. We fixed it. The left and the right side broke at 18 months. So this is stainless steel. It gives you some opportunity to understand and challenge and tackle the problem before titanium just gives way. So both are strong. Stainless steel is stiffer, but stainless steel has more ductility. It gives a zone of breathing to act before catastrophic failure. Coming to clinical cases, this is a 1-2A3, a transverse fracture in mid-shaft humerus. As you can see at 2 weeks, this is the fracture gap. This is at 6 weeks. This is 16 weeks. And this is a year. So nature has followed all the principles of physics and mechanics, and the patient has a beautiful functional outcome. Now, in our eagerness to return outcomes, we marry metal to the bone. So this is another example of a humerus fracture, and a plate has been fixed and a plaster slab has been given. So the metal and bone now have to stay married. So this is 3 months. This is 5 months. And this is 8 months. Divorce. So what went wrong? When we didn't do anything, as we say, conservative treatment, the bone went on to unite. And when we fixed a plate, the bone became happy. So did the bone become unhappy, or did we make it unhappy? So the usual reasons the patients are generally given, and this young gentleman came up with, and I made a note of all them, are reasons which cannot be objectively explained. Implant quality poor. It is just poisoning the mind of the patient against the previous doctor. Patient bone quality is not so good. How can a 20-year-old boy's bone quality not be good? Yeah, it may not be good if you were taking steroids for some other ailment, but it was not the case. Plaster was removed too early. Surgery was done wrong, but what was done wrong? Not explained. Nailing would have been better. Plates are not put in this kind of case. Patient started doing things he shouldn't have been doing, like doing dumbbells or combing his hair. Did the patient fall back again? Calcium tablets were not started. So these are reasons of a given of not a rational, logical mind. These are emotional reasons. A more analytical mind will think of what may have happened to the bone vascularity during surgery. Was the limb being loaded excessively? So try to find out what kind of activities he was doing once he was comfortable. Were they high strain conditions? And what was the material property that was used? So now you know, because this failed slowly without any deformation, this must have been a titanium implant. So we will talk of this concept, high strain conditions. And to understand this, you must all read the strain theory of Perrin. So what is this strain theory of Perrin? The strain theory tells us that human bone or animal bone, the tissues after fracture or even before otherwise, forearm is X-ray. Dominant right hand dominant tennis player like no forearm is X-rayed. Right versus left. His right side bone, forearm bone, will be bigger in size. The cortices will be thicker and the bones will be much stronger. So tissue is forming in response to the mechanism. Because something in the bone detects motion, and that something is the osteocyte. With its canaliculi interacting with each other, osteocytes sense motion. When they sense motion, they transfer or convert this mechanical signal to chemical reactions, concept known as mechanotransduction. Reactions then help form bone or lyse or destroy the bone. So the osteocyte, which is the most abundant cell in the human bone or animal bone, is a mechanosensor which senses motion and converts that into chemical stresses, chemical reactions. So the strain theory of Perrin says that, say, the two cylinders are broken bone ends, and you can see 6-cell column in between them. So say this fracture length is L. When the bone is loaded in tension, you can see a change in the shape of the cells. So there is an increase in the length of the fracture gap. So change in length over the original length multiplied by 100 is the strain. That is how we calculate the strain. So let us take two examples. This is a 1 cell thick gap between the two broken ends. And this is a 4 cell thick gap between the two broken ends. So if we calculate the strain at the 4 cell thick layer, if on stretching the cell thickness, the fracture gap has increased by 1. So 1 upon 4, the strain is effectively 25%. But if the fracture gap is only 1 cell thick and it has increased, so the strain on the healing cell is 100%. So if the fracture gap is small, the strain environment is very high on healing tissues. And if the fracture gap is more, then the strain environment is less on healing tissues. So this is a concept and this is a fact now. Bone forms when the strain is less than 2%. Cartilage forms when the strain is around 10% on healing mesenchymal tissue. And granulation tissue forms when the strain is 100%. So if there is too much motion at the fracture site, a pseudarthrosis will form, and we say it's a fibrous non-union. With time, that fibrous tissue gradually gets converted to cartilage. So we will see cartilage at the ends of the bone, but bone never bridges across. So it becomes a non-union. So this diagram was explained by Powell almost 100 years ago. He said whatever the stresses and whatever the along a certain path, and eventually if the mechanical cartilage will convert into bone, and fibrous tissue can also get converted into bone. So this is the concept of now understood, and I will take you through clinical examples. So strain tolerance in this conservatively managed humeral fracture. There was a large fracture so the strain on the healing tissues was low, bone, callus. On the other hand, the strain tolerance in this small fracture gap was very high. Absolute stability, this was relative stability. So there was micromotion. This micromotion created high strain on healing tissue. When there is high strain on healing tissue, the chances of granulation tissue forming will be higher. And this is eventually what led to poor bone healing. A clinical example, this is a spiral fracture of the proximal femur with some fragmentation. The surgeon opted for absolute stability, but there are certain fracture gaps visible. It created a high strain condition, and eventually this happened. So if you see this critically, the spiral fracture has disappeared and the non-union is now fundamentally transverse. So all multifragmentary fractures, when fixed and when they eventually go into non-union, eventually are left with a single fracture line. So when there are multiple fracture lines, the strain is distributed over multiple areas. But as the fracture fragments start uniting, the strain concentration starts getting higher and higher. So a simple spiral fracture became a transverse non-union. you have understood bending forces, torsional forces, axial forces. You have understood strain. You have understood this deformation. But with plates, another unique phenomena happens, like you can see in this diagram here. The strain is the red triangle. So when a plate is applied on one side of the bone, the strain under the plate on the side of the plate is almost negligible. So bone may form there because the deformation is much less. But on the side opposite, where the strain is higher, there is no bone formation, there is granulation tissue formation. And that's how the implant on cyclical loading starts bending and deforming. So to summarize, broken bone is programmed to heal. We as surgeons can modify the healing environment. We must customize the mechanics to the requirement of the fracture, not to what we know. And whatever we do, we must try to avoid high strain conditions in any fracture fixation. Thank you.
Thank you
We are
very
now
much.
open to questions.
Thank you very much, Ritabh. As usual, you have this ability to break down things into very simple formats so that people can understand. And I'm sure if there are any questions, the participants will be happy to ask them. And I'm sure Ritabh will be happy to answer them. So over to the questions from the participants. Anything in the chat?
So right now we have not, but
You can stop sharing your screen, Ritabh. Stop sharing your
Yes.
screen. Yeah, great.
Yes, sir.
yeah, thank you, sir. Thank you very much. So I have gone through the question paper. There are a few questions, like one thing they repeatedly asked about bioabsorbable implants. So how it is different from the normal ones?
Yeah, bioabsorbable.
Bioabsorbable implants, basically like Vicryl is an absorbable suture, polyglycolic acid, polylactic acid. So we have implants made of those materials. We had plates and K-wires for use in pediatric patients for finger fractures. They came up in a big way. The benefit was that there is no need for a repeat surgery for removal. But the problem is all the bioabsorbable implants start degrading in the corrosive saline environment of the body. So they start losing their strength and stiffness. But if the fracture has not healed appropriately in 6 weeks and the implant has become weak, the fracture fixation will fail.
Also, some of them had this tendency to produce granulomatous reactions. But the newer generation ones are better for that.
Yes.
Use some of these KYs and pins both in pediatrics and
in fractures, where they have a potential for faster healing. Like finger fractures, these things have merit there.
So another thing they have asked about the guiding principle of implant removal. So, sir, what we find for like titanium implants, it's difficult to remove.
Yes.
So my another question which I want to ask is like if we can put the steel screw, which is not usually done, so that may be little easier.
No, that's a very wonderful thought. It's a very wonderful thought. Use a titanium plate and a stainless steel screw. That is actually a wonderful thought. So yes, there is some galvanic corrosion that may happen because of movement of metal. So this is not something that is recommended that you can mix and match, but the corrosion phenomena is negligible. This can be done, and stainless steel screws are far easier to remove. So it's a very novel concept, very interesting, but we cannot recommend it as a routine or something that should be done in clinical practice. Titanium is a nightmare because of titanium's less ductility. the moment the handle is turned, the screwdriver is turned, either the screw will break. Titanium is softer than stainless steel, so the heads deform. The plus side of titanium is it's easier to cut through. Using a burr hole drill, you can burr the head of the titanium screw much easier than stainless steel. Stainless steel removal is broken screw is a bigger challenge than a titanium broken, but stainless steel generally comes out quicker.
Yeah, there is one question, sir. They have asked about to reduce strain, the fracture gap should be less. He's asking about the question
No.
after.
To reduce strain on healing tissue, the fracture gap should be more. That is what nature does. So whenever there is a fracture, we will see a fracture line on day one. Suppose we manage it conservatively. 4-6 weeks later, we see that the fracture gap has widened. That is what nature does. So the cells at the zone of fracture undergo cell death because of loss of blood supply. So nature during conservative treatment widens the fracture gap. So widening of that fracture gap reduces the strain on the healing tissue. So that is what happened in the humerus fracture example which I showed. With a fracture gap, the tissue healed well. And the moment we reduced that fracture gap but did not abolish it, had we abolished that fracture gap, the strain would have been almost 1 or 2% and bone would have formed directly across the fracture gap. But because we left a gap, there was micro motion and there was high stress on the healing tissue.
So one of the things is not to confuse stress and strain, okay? When you're talking about strain, you're talking about the deformation that occurs either in the bone or in the implant, and that's when your stress is the forces acting in that area. So they're two different.
So they have asked that whatever you have already explained about stress, strain, and Young's modulus of elasticity, I think thrice in the DNB.
Okay.
So already you have shown the graph also on the diagram. So little bit more about Young's modulus of elasticity, sir, if they need to write.
Yes. So if Young's modulus of elasticity is essentially stress over strain. Stress over strain is the slope of the graph which I had shown. So that is a measure of the stiffness of the implant. And as you saw the graph, it went up, then it suddenly came down, and then after some time the line stopped and broke. So the point where it breaks off, that is known as the strength of the material. But the moment its shape changes, that is in the plastic zone. So the stiffness, the modulus of elasticity is a measure of the stiffness of a material. So
Okay, great. Thank
it
you
is a
very
measure
much.
of stiffness
I think,
within
no
a
more
certain.
questions. Pardon?
Yes, sir. Sir is answering, sir. So,
Oh, sorry, you're still answering a
oh,
question.
yes, sir.
So all materials are a little bit elastic in narrow zones. So if you take glass, it just breaks. So it is not elastic. It is elastic, but not ductile. So you see in the modulus of elasticity, glass or ceramic for that material in THR, if it falls, it cracks. Titanium and stainless steel balance out the ideal implants for fracture fixation because their modulus of elasticity is much, much higher than that of healing bone. They have reasonable strength to protect the bone from fractured bone from abnormal stresses and strain. But they have to eventually share load with the bone. They can't take the load permanently. So they have to allow the bone to heal. So if you see, the stiffness of titanium is half that of stainless steel. So a titanium implant helps in a little more deformation of healing bone. So the concept of MIPO with titanium is much better compared to stainless steel. Stainless steel is very stiff, so it does not allow healing bone to deform. So that was the challenge faced in distal femur fractures fixed with stainless steel plates. So now the concept is evolving how to reduce the stiffness with a stainless steel plate. So Sir would know more about this, the concept of far locking screws. I have no personal experience, but now the screws don't lock near the near cortex of the plate. They lock only in the far cortex, so that the near cortex also has a little bit of strain to allow favorable bone healing.
Yeah, the far cortical locking is still not become widely used. It's used in very limited this thing, and the particular implant that was at one time going to be available in India, but then they withdrew it from the market. And the other thing that Synthesis was trying to develop, which was the dynamic locking screw, where this thing moved within the outer shell, that failed some of the biomechanical tests, so they didn't bring it to the market. So I think we don't have a very good option for far cortical locking available with us. There is some people are sort of improvise on it by over drilling the near cortex so that the screw is locking only on the plate and in the far cortex, but you really don't know what the actual effect of that is in terms of the actual load changes, etc. So no one's actually done work on that, or people have done work on that, but it's not very clear yet. So I think we will have to still wait on that. So they have changed the implant sort of characteristics by reducing the number of holes in the fracture site, area covering the fracture, etc. That's happening, but again, not yet widely available. So we'll have to wait for that to happen before we can really talk about it in more detail. Okay, I think.
Just one thing, sir. One question in the chat box which was not yet answered. Although there is one question: how titanium implant are better than SS implant? That is already answered by sir. Also, what he has confused with, that sir has explained, on plating side there is more callus. That line he want to know.
On plating.
That, yes, sir.
In plating.
Yes, sir.
Plating.
What? Yeah.
In plating, there is asymmetrical strain across the width of the fracture. Near the plate, there is no deformation of healing tissue, or very negligible. But on the opposite cortex, there is a lot of deformation. So
I think your sound is getting.
A lot of deformation, granulation tissue deformation, their cartilage will form. So when there is asymmetrical strain across the width of the fracture, when the plating is done. When a nailing is done, the nail is inside the bone. So the strain and stresses are equally distributed around the diameter of the bone. With a plate, the stresses are more on the other side. So that is why concepts have come of trying to put a plate on the other side of distal femur, or put a nail or something else. So the stresses are more on the side opposite the plate. So when stresses are high there, so strain is also high because there is more movement. When there is more movement, the tissue that will form there is granulation tissue. In the center of the bone, where the stresses are lower, there cartilage will form, and that will eventually go on to heal and become bone. And where there is bone under the plate, there bone will form. So bone forms closer to the plate, cartilage in the center, and granulation tissue away. But the stresses are high, maximum away from the plate. So with plating and with stainless steel plates, which are very stiff, this asymmetrical kind of bone formation causes a lot of delayed healing. And there were challenges, and the failure rate in distal fracture fixation still remains very high worldwide. So this concept has to be understood, this gold principle of how much relative stability does a fracture need. That is a question which we still are awaiting an answer from. And experience has taught us that surgeons like Mukhopadhaya sir, Mukesh Jain sir can intuitively apply it to the patient's fracture. Intuition comes from experience, but the gold standard answer mathematically and physically on pen and paper that if there are 5 fragments with 6 centimeter length and 12-hole plate, mathematically calculate this should be the fracture gap, and then we don't have that answer yet.
True. But I think some of it is luck more than intuition. But look at that. But okay, thank you very much. I think we need to close that today. That was great, Ritabh, as usual. And thank you very much for being part of this program. And
thank you for the opportunity, sir.
You're welcome. And until next week, bye to everybody. We'll see you again next week. Bye.
Thank you very much, sir.
Thank you.
Great, sir. Thank you, sir.
I need to go back into the OT.
Thank you, sir.